Think we can start now. Dr. Nisha,
Yes, ma'am.
please start.
Okay.
Dr. Arunima, please stop screen sharing. We are going live now. Dr. Nisha, please start.
Hello, everyone. I welcome you all for the ISC National Online PG class. Sorry for my voice. I am Dr. Nisha Jain. I am working as an assistant professor at VMMC and Safdarjung Hospital, Delhi. Today, we are discussing about the anatomical and physiological differences in pediatric and adult patient. I'll be working as a screen coordinator for today's session, and I welcome my screen coordinator, Dr. Arunima. She is working as a senior resident at NRS Medical College, Kolkata. Before proceeding ahead, let's invoke blessings of Ma Saraswati on the auspicious day of Dhanteras. Just give me a time. Arunima, can you stop your sharing, please?
I have stopped. I have stopped my sharing.
Is there a problem,
Sorry,
Dr. Nisha?
sorry for the delay. I'm just Ma Saraswati is taking time to give us blessings. Sorry for the delay. SA National Honorary Secretary, Professor Sukhminder Bajwa sir is with us. I welcome sir and request sir to say few words for today's session.
Dr. Nisha, sir will be joining us shortly.
Okay, ma'am.
Then he will address us. Meanwhile, we can just these classes are held every Monday at 6:30 p.m. And today we have got the topic, as you have already told, of the differences between the anatomy and physiology between a child and an adult, which is very important for any anesthetist in the anesthetic management. And to dwell upon this, we have eminent luminary amongst us from the northeast state of Arunachal Pradesh of our country. And we are very happy to have them with us here, both the faculty and the student presenters. And sir will be joining us shortly and address us. So I hand over to Dr. Nisha to please proceed.
Thank you, ma'am. I now request Dr. Arunima to please introduce our esteemed faculties for today's session. Dr. Arunima.
Thank you, Nisa. I'm Dr. Arunima, working as a senior resident in anesthesia in NRS Medical College, Kolkata. Very good evening to everybody and welcoming you all to our ISA National PG online class. I am here to introduce our renowned faculty, Dr. Ramapati Shanal sir, Dr. Noemi Sharing ma'am, and Dr. Taji Lucy sir. Professor Dr. Ramapati Shanal sir, he is professor and head in Department of Anesthesiology and Critical Care from Tomoruba Institute of Medical Sciences in District Arunachal Pradesh. Next, Dr. Noemi Sharing ma'am, she is IS Secretary in Arunachal Pradesh State Branch and working as Associate Professor in Department of Anesthesiology and Critical Care from Tomoruba Institute of Health and Medical Sciences. She is having her PG teaching experience of 3 years and having 10 publications till now. Dr. Taji Lucy said he is Honorable IAS Secretary in Itanagar City Branch and working as Assistant Professor in the Department of Anesthesiology and Critical Care in Tomoruba Institute of Health and Medical Sciences from Arunachal Pradesh. Now, I am handing over the stage to the faculty and requesting them to introduce the PGTs and carry on the class. Before that, just a small announcement. Everyone joined is requested to kindly keep microphone muted and videos turned off. You can type your queries in the chat box after giving your introduction. All the queries will be addressed at the end of the session. Now it's over to you, sir, ma'am.
Good evening, everyone. We have two final year DNB PGs presenting today, Dr. Milo Epo and Dr. Animesh Namdev. And I hand over the mic to coordinator begin.
Good evening, everybody. I am Professor Ramapati Sanyang, Professor and HOD of the Tomoruba Institute, from where we are going to conduct the CME today. And first of all, I'd like to thank the IASA national body and specifically our Honorary Secretary, Professor Bajwa, for giving us the opportunity to conduct this CME. And I thank Dr. Madhuri, Dr. Nisha, Dr. Arunima for conducting this, helping us. And overall, an advanced happy Diwali to all of you. We start our session as such. Thank you.
Should we start the class?
Yes, please.
Thank
Please
you.
go ahead.
Good evening, everyone. Respected faculties and my dear colleagues over online today. Today, we are going to present our class on anatomical and physiological differences in pediatric from adult. Today we are going to briefly discuss the differences in the airway and respiratory system, the cardiovascular and central nervous system, renal and hepatic system, and hematology and fluid distribution in pediatrics. Now, to start with, the newborns or the children are not a small adult as they they grossly vary in physically, as I've shown a picture that I've taken from Smith and Pediatric anesthesiology, showing the body proportion of an newborn to an adult in various aspects, like in weight. In the newborns are around 1/21 of the adult weight, and in surface area they have around 1/9 of the adult surface area, and in length they are around 1/1.3. and and also they vary in metabolic. They have metabolic differences and immature function of the organ systems. The body weight of a newborn doubles by 4 months of age, triples by 12 months, and quadruples by 24 months. The length or height of the newborn, they double by 4 years and triples by 13 years of age. And for the body surface area calculation, if we know the weight and height of the baby, we can calculate it by this formula. It's square root of weight into height divided by 3,600, and we get the body surface area in the meter squared. And on the right side, I've taken a picture from Smith again, showing that this is a body surface area normogram for infants and young children. And if we know the weight or height of children, we can calculate the body surface area accordingly from this normogram. The classification, according to the age group, we can classify the pediatrics and as neonates. That's from birth to 28 days of life. Infants, that's from 1st to 12 months of age. Toddlers, from 1 to 3 years. Preschool child, from 3 to 6 years. School age, 6 to 12 years. And adolescent, from 10 to 18 years of age. And according to the gestation age, we can classify them as less than 28 weeks. We call them as extremely preterm. 28 to 32 weeks, they are very preterm. 28 to or 32 to 34 weeks, they are moderate preterm. And from 34 to 37 weeks, they are late preterm. And according to the body weight, we can classify them as 2.5 to 4.2 kg, they are normal weight. And below 2.5 kg, they are called low birth weight. Less than 1.5 kg, very low birth weight, and less than 1 kg as extremely low birth weight babies. Now next, coming to the airway. The babies have, especially the newborns, they have a large head with prominent occiput. Therefore, a shoulder roll or neck extension, shoulder roll must be used for neck extension. So that's to align the airway axis. And the upper airway, they have narrow nares, which gets easily blocked due to inflammation and secretions. And they are obligate nasal breathers till 5 months of age, and mouth breathing occurs only during crying. Therefore, care must be taken while passing a nasogastric tube in the pediatric age group, and nasal intubation should be avoided, especially below the 6 years or 6 months of age. Coming to pharynx, they have large tongue in proportion to oral cavity. Any anatomical imbalance between fixed bony cavity and soft tissue may cause narrowing of the airway. And pharyngeal lumen, they may collapse with negative pressure generated through any inspiratory effort made by the baby. The epiglottis, they are floppy and omega shaped, and they are the epiglottis is angled away from the axis of the trachea, and also they have thick epiglottic falls. Therefore, it's difficult to lift the epiglottis during direct laryngoscopy. Next is the larynx. The larynx is more subphalar and anterior in newborn and infants. It lies at the level of C3 in neonates, C4 in infants, and in adults it lies at the level of C5, C6. Therefore, straight blades are preferred for direct laryngoscopy of newborn and infants. And the vocal cords are more anterior, and they are more slanting towards the posterior side. Therefore, it's difficult for direct laryngoscopy, and there's always a increased risk of accidental tube dislodgement in babies. The cricoid cartilage, they develop fully at the year of 10 to 12 years of age. Therefore, reduced cricoid pressure should be applied while intubating in this age group of the patients. And the recent studies, they've shown that they sees that the larynx is more of a cylindrical structure than they used to say are classical funnel shape larynx. And the narrowest part of the larynx, they are the underdeveloped cricoid cartilage, which is now said to be elliptical rather than the circular shape. Therefore, ET tube size and type should be wisely chosen while intubating a baby or an infant. This is the ET tube size calculation. For ET tube size calculation, in a new preterm neonate, age of 0.7 to 1.5 kg, we can use an ET tube size, uncuffed ET tube size of 2.5 mm, and in the weight of 1.6 to 3 kg, it's 3 mm ET tube, and the term neonates, it's 3.5. First year to 1 year is 4, and just 2 years 4.5 mm uncuffed tube. From 2 years to 6 years, for ET tube size calculation, we can use this formula. That's for uncuffed, we can use the formula age of the baby divided by 4 plus 4, and for uncuffed tube, we can use the formula age divided by 4 plus 3.5. And for the depth calculation, estimation of the depth from the lip, we can use the formula age divided by 2 plus 12, or we can use the size of the ET tube into multiplied by 3. But to always confirmation of the ET tube placements would be done by auscultation, and bilateral air entry should be confirmed. And roughly also we can use the the diameter of the children's little finger to estimate the size of the ET tube. Coming to the trachea, the trachea of the newborn or the infants are narrower, and any little edema may cause a significant narrowing of the airway. I've taken a picture here showing the tracheal lumen of an infant and an adult, in which the infant has a 4 mm of millimeter diameter of and adult has 8 millimeter diameter, and any edema of 1 millimeters circumferential edema that may cause reduction of 75% reduction in the cross-sectional area, and while in adults it's only up to 44% of the cross-sectional area. And the with this reduction in 75% cross-sectional area, the resistance or airway resistance increases to 16 times, and while in adults it's only 3 times. And the trachea, they are shorter in length, up to 4 centimeter as compared to the 10 to 12 centimeter in adults. And the right and the left main bronchus, they make almost equal angles, more horizontal, while in adults, left main bronchus form more acute angles. Therefore, chances of endobronchial intubation is high in newborn and infants, and the chances of endobronchial intubation is also equal on both sides.
Now I'd like to ask both of you, as well as presenter, as well as the audience who are present here, which one will you choose? Epo?
And for neonate, I'll choose a straight blade for direct laryngoscopy.
Can you tell the reason?
Because they have the larynx is high in infants so neonates.
Epiglottic fold. You said something about epiglottic fold.
And epiglottis is floppy and omega shape, demo fallback, and the
Okay. Next question. One more we're going to ask. Which do you think is the narrowest portion in airway? That is in subglottic region.
You can mention the options also, madam.
Yeah.
Vocal cord, at the area of cricoid cartilage, at carina, at the false vocal cords. We'll give 30 to 45 seconds for the answers. Meanwhile, Dr. Appo and Dr. Animesh, your voice is echoing. Please take care. Choices are vocal cord at the area of cricoid cartilage, at carina, and at the false vocal cords, which is the narrowest part of the pediatric subglottic airway. I think a lot of students have given answer is B, at the area of cricoid cartilage. Is that right?
Epo?
Uh,
You can tell. Yeah.
Yes,
The
ma'am.
answer is at the area of cricoid cartilage. Some people, some literature nowadays, they have come up with the publication that in cadaveric position, that is during anesthesia only, vocal cord may be the narrowest portion. But then while intubating the tube, the vocal cord gives away since it is piece of pliable. So, but when the patient is awake or the child is awake, it is always the cricoid region, which is narrowest in. And again, by MRI scanning and all nowadays, they are telling that the cricoid portion, the larynx may not be conical as previously thought. It might be cylindrical. That is the thing nowadays. Some of the publication are telling. Okay. Most of you are correct. The option is B. Okay, you may continue with the presentation.
Coming to the organ system, the first is the respiratory system. Firstly, to speak about the chest wall, the baby, the chest wall of the baby is more compliant. The ribs are soft and horizontally placed, limiting the inspiration. Therefore, bucket handle movement of the rib cage is limited. The adult configuration of chest wall is achieved by 10 years of age. The intercostal muscles are not mature, and ventilation is primarily therefore diaphragmatic. The diaphragm is more horizontal, and they are deficient in type 1, which is type 1 muscles. The type 1 muscles which are slow twitching and fatigue resistant. In the preterms, they have around 25% of the diaphragm muscles are type 1, and in the newborns, term babies, they are around 35%, and in adults they reach up to 50%. Therefore, infants and neonates are get fatigues more easily. Coming to the lungs, they have immature elastic fibers. Therefore, the lung compliance is decreased, and the newborn has 10% of the adult alveoli numbers, which reaches to adult level by 12 to 18 months of age after months of age. Then the maturation is not complete until 8 years of age. The surfactant production by type 2 pneumocytes begins at 20 weeks of intrauterine life, but they increase between 30 to 34 weeks. And the surfactants, they have to keep the alveoli fine and distended. But in the preterm newborns, the surfactant level is low. Therefore, preterm newborns are more prone to atelectasis and respiratory distress. The mechanism of continuous neonatal breathing is the onset of breathing activities occur not at the birth but in the utero as a part of normal fetal movement. The clamping of the umbilical cord initiates rhythmic breathing. The relative hyperoxia with air breathing compared with low fetal PaO2 augments and maintains continuous and rhythmic breathing. The continuous breathing is independent of level of PaCO2, and the breathing is unaffected by carotid denervation, and hypoxia depresses or abollishes continuous breathing. The work of breathing for each kilogram of body weight is similar in infants as well as adults, but the oxygen consumption of infant is twice that of an adult, which is 6 ml per kg per minute in infants, and in adults, which is 3 ml per kg per minute. The, the tidal volume, which is small and relatively fixed in the therefore, the minute alveolar ventilation is more dependent on the respiratory rate rather than the tidal volume. The greater oxygen consumption requires increased respiratory rate, and increased alveolar ventilation leads to rapid induction and emergence from volatile anesthetics. There is the functional residual capacity is reduced in babies. Therefore, they have a high chance of rapid desaturation, and in the closing capacity, they exceed FRC, which can lead to atelectasis and airway collapse. The maintenance of the functional residual capacity in young infants is achieved by sustained tonic activities of inspiratory muscles throughout the respiratory cycle. The breaking of expiration with continual but diminishing diaphragmatic activity, narrowing of the glottis during expiration, inspiration starting with expiration period, and the high respiratory rate in relation to expiratory time constant. But all this, therefore, all this mechanism which sustain the FRC in the babies are lost with anesthesia or muscle relaxant. Therefore, in anesthetized babies, the FRC is always reduced. The central apnea or apnea of prematurity is common in preterm infants. It's due to immature nervous system, impaired hypoxic ventilatory response, and impaired hypercapnic ventilatory response. Therefore, in preterm babies, the hypoxic and hypercapnic state does not increase the ventilatory rate. The risk of postoperative apnea is they are the preterm neonates less than 60 weeks of post-conceptual age, anemia, hypothermia, sepsis, and neurological abnormalities.
Okay, Dr. Nimesh, you're going to answer. Let's put it to the audience first. Which of the following is not true regarding the mechanism of onset of breathing? Breathing starts in intrauterine life, which is not true. Maternal alcohol ingestion and cigarette smoking depresses breathing. Hypoxia and raised partial pressure of carbon dioxide in blood stimulate rhythmic breathing at birth, and the clamping of the umbilical cord and increasing arterial oxygen tensions with air breathing. So which is not true? This is the question.
Screen coordinators, please check on the options.
Yes, ma'am.
Sure, ma'am. Sure, ma'am.
So the options are breathing starts in intrauterine life, maternal alcohol ingestion and cigarette smoking depresses breathing, hypoxia and raised PaCO2 stimulate the rhythmic breathing at birth, and D is the clamping of the umbilical cord and increasing arterial oxygen tensions with air breathing. What are the options, screen coordinators? What are the answers given by the
Most of the people
audience?
answered option A.
Option C.
Option A. Okay, ma'am. Please discuss the options, answers.
Yes, let us look at the answers. So the recent studies contradict the traditional theory. So the fetal asphyxia stimulates the chemoreceptors and produces gasping, which is followed by rhythmic breathing. Indeed, clamping of the umbilical cord and increasing arterial oxygen tensions with air breathing, with the breathing of air, and resultant relative hyperoxia from the normally low fetal PO2 initiate and maintain rhythmic breathing at birth. So hypoxemia less than 60 millimeter of mercury results in significant increase in the ventilation in all groups except in the newborn, particularly the premature infants, where ventilation is decreased by hypoxemia. So the main what we were trying to say is that as we see that the can you go to the options? Yes. So all these are true regarding the breathing. Breathing will start in the intrauterine, right? There is a rhythmic breathing, maternal, and will definitely depress breathing at birth. But this hypoxia and raised PaCO2 will not initiate the onset of breathing, right? So this is the wrong answer. Actually, what it looks like, the question looks like, if there's a hypoxia, there's a raised PaCO2, there will be stimulation of breathing. But as evidence suggests, as we have put in the next slide, that the hypoxia actually depresses the breathing. So in the next slide, please go. So you can see the hypoxemia actually depresses the breathing. It will significantly increase ventilation in all groups except for the newborn. Okay, let us progress to the next one.
Okay, sir. Okay, the next organ system, we come to the cardiovascular system.
Just before you start this, one thing that I would like to tell is regarding the reduced FRC in a newborn. Why there is a reduced functional residual capacity in a newborn? There are certain things that you should remember. First, the alveoli are not well developed in number, as well as the wall is not elastic. So the number of alveoli is reduced, they are small, the wall is not elastic. The conducting airway is not supported very much because of the less tissue of the lung parenchyma, as well as there is less support of the muscular. So it collapses very easily. The third thing, all the ribs, they are actually cartilaginous. So when the newborn tries to take a deep breath, the whole chest wall collapses. Actually, the chest wall should move out so that the airway is stented. So all this, what causes is a decrease in the FRC. So total lung capacity and the FRC ratio is much more increased, and therefore since the FRC is less because of the collapse of the airway, because the alveoli are not able to stretch to the maximum, and third, there is a collapse of the chest wall as such, which acts as a support in the adult or in children. There is less FRC, and we have already discussed what are the effects of an FRC, and we'll discuss somewhat later on also. Please proceed.
So we go on with the cardiovascular system. When we talk about the cardiovascular system in infants and neonates, it is very important that we at least know about the fetal circulation. So the significant aspect of the fetal circulation is, the first thing is it has got a low resistance placental vascular bed, so that the all the systemic all the blood from the systemic circulation preferentially move to the placenta. And next is it is a parallel circuit, as the both ventricles provide blood to the systemic circulation, and this parallel circuitry is also made possible as there are shunts which allow mixing of oxygenated and deoxygenated blood. So as we can see, this is a schematic diagram of fetal circulation, and here we can see the shunt. The first shunt is the foramen ovale. We see it is essentially a one-way valve from in between the right atrium and left atrium. So this is a flap valve, and it allows only one way direction blood flow from the right side to left side. The next shunt is the ductus arteriosus, which which is a vascular connection between pulmonary artery and the aorta. And since it is a vascular connection, it allows blood from either side of the uh, connection, but the flow is directed as per the pressure gradient. Since in utero life, the right side of the heart has got higher pressure than the left side, the mostly the shunt is from right to left. So the next shunt is the ductus venosus, which between the placenta, which directly drain into the IVC or inferior vena cava through this shunt. Next, we can just see an overview of this circulation. So the placenta gets the blood from the whole systemic circulation, or from by the two umbilical arteries, and this is the site of the oxygenation in utero fetal circulation from the maternal circulation. And after oxygenation, the blood drains into the ductus venosus via single umbilical vein, and to the directly into the IVC. So the blood in the placenta and ductus venosus is the most oxygenated blood in the this fetal circulation. So IVC also get the blood from the lower portion of the body, and uh, this all this IVC drain into the right atrium, and there is a right atrium has some crista dividends, which preferentially directs the blood from the ductus venosus to the left atrium via foramen ovale. And so the left atrium gets mostly the oxygenated blood from the ductus venosus, and left atrium also get the blood from the pulmonary vein, but since the uh, blood in the pulmonary circulation is very minimal, and so the even the mixing doesn't cause uh, that much significant reduction in the oxygenation. So this blood from the left atrium to left will go to left ventricle, and it is pumped out in the aorta. So this from the aorta it goes into circulation, and this there is a important thing we have to see, that the presence of the ductus arteriosus is usually in most cases it is to the close proximity of the left subclavian vein. So the uh, this is important to us because the if the ductus arteriosus is draining into the aorta near the left subclavian vein. So the upper extremity will get the if we get any sample from the left side of the upper arm, or if we give check the pulse oximetry in the left upper arm, so we will see the sample as the post ductal blood. So it is also important because the blood to the brain is getting mostly the oxygenated blood via the both of the left and right carotid artery, brachiocephalic trunk and the left carotid artery. So so the blood brain is getting is the unoxygenated, and so after this circulation, the blood come again to the by a superior vena cava and drain into the right atrium, and by the same mechanism it preferentially directed towards the right ventricle, and it drains into the pulmonary artery. But since in utero the pulmonary vascular resistance is quite high and pulmonary artery pressure is quite high, so the most of the blood from this pulmonary artery goes via this shunt to ductus arteriosus and mixes it in the ascending aorta, yeah, or the arch of aorta. So next, the physiological changes at birth. So cardiopulmonary system undergo major changes after delivery of the baby and clamping of the umbilical cord. The the parallel circuit that was there in utero life, it gets transition to the series circuit, as uh, there are pulmonary circulation, systemic circulation now, and they are just uh, connected in series. So this transition triggers multiple physiological changes. The two very important things that happen at the birth is, first thing is the placental removal. So low resistance placental vascular bed is removed from the circulation. See, it has very great impacts on the circulation. As the first thing is the portal venous pressure decreases drastically, and since the portal venous pressure is reduces rather than in relation to the IVC, so the ductal venosus gets closed. So the first shunt gets closed due to this pressure gradient reversal. Next impact, this low resistance, since the uh, low resistance placental bed is removed from this circulation, the systemic vascular resistance drastically increases. So it also leads to the increased afterload to the left ventricle. Next important thing that happens in the second important thing that happen at the birth is the newborn takes the first breath. So there is increase alveolar oxygen, the lungs get expands, and there is increase in the pH, and there are neurohumoral mediators, and which release the nitric oxide in the pulmonary circulation. This all leads to the relaxation of the pulmonary vessels, which are otherwise in constriction state in utero life. So this relaxation of the pulmonary vessel decreases the pulmonary vascular resistance, and so this decrease in the pulmonary vascular resistance and increase in the systemic vascular resistance, both of them together lead to increase in the left atrial pressure. So since we have seen that the shunt that was there in the between the right atrium and left atrium, it was just a one-way valve. That was a flap valve. So as the left atrium pressure increases as relative to the right atrium, so the uh, foramen oval gets closed. So that is the mechanical closure of the foramen oval at the time. The next impact that is having due to the decreased pulmonary vascular resistance is it reverses the flow in the ductus arteriosus. So the reverse flow leads to the exposure of the ductus to the oxygenated blood, and there is decreased prostaglandin since the placenta is removed from the circulation, and this leads to the closure of the functional closure of the ductus arteriosus at birth. So this is the mechanism of transition from the fetal circulation to the adult circulation. Now, this new circulation is quite fragile, and especially in preterm neonates, there are factors which can reverse these changes. And this sudden return to the fetal circulation, we call it transitional circulation. So, the main important risk factors which leads to this transitional circulation is hypoxia, hypercapnia, acidosis, and hypothermia. Basically, these risk factors leads to increase pulmonary vascular resistance by increasing the pulmonary artery pressure, and increase in the pulmonary vascular resistance at the as the uh, 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 these shunts are not closed properly at birth, and that especially in preterm neonates. So they may reopen, and foramen ovale may reopen and leads to the right to left shunt, and ductus arteriosus may allow the due to the pressure gradient changes, it can allow the reverse blood flow. And in severe cases, it may lead to severe hypoxemia also. In most of the cases, hyperventilation, just giving the hyperventilation to the baby can decrease the arterial PCO2, and it can cause the pulmonary artery pressure to return to normal. So, coming to the heart, the heart myocardium has less contractile myocardial cell mass, and it also has low intracellular calcium store in the neonatal myocardium. So, due to these two reasons, there is reduced myocardial contractility, and the ventricles are also less compliant. And since the uh, since the myocardium could not stretch more than the stroke volume is quite fixed. So even if we increase the preload or increase the end diastolic volume, the afterload, or we cannot increase the stroke volume significantly. So due to this fact, the cardiac output is predominantly dependent on heart rate. So whenever we need to increase the cardiac output, we need to increase the heart rate, as the stroke volume is relatively fixed. So in case of bradycardia, due to any reason, it is very poorly tolerated in neonate infants, and it may lead to asystole also in severe cases. So the
So,
myocardium.
yes,
Sir.
I would like to explain this. Important part is the myocardial cell mass is fixed and it cannot increase. So the important part is, as you increase the preload or you make more return to the heart, as it happens in the adult, the contractility increases according to the Frank-Starling law. But here the Frank-Starling law doesn't act because there is a less contractile myocardial. They have a different low calcium stores. So this Frank-Starling here will not act, and therefore the output will only depend upon the rate of the heart. And therefore, but usually the myocardial tissue does not get fatigued. Why? Because it has a high glycogen concentration, and therefore is more tolerant to hypoxia. So this is the basic idea of this slide. Please go on.
Thank you, sir. So the myocardium has high glycogen stores, as it is accustomed to the hypoxemic environment in utero. So fetal heart is quite more tolerant to hypoxia as compared to the adult heart. So in case of hypoxia, the chances of ischemia is lesser as compared to the adult. So the neonates has a underdeveloped baroreceptor reflex, and also the sympathetic nervous system is not quite developed at birth, at least in the initial few months. So due to these two reasons, any intravascular depletion due to hemorrhage or anything, it may cause profound hypotension without any reflex tachycardia. Since sympathetic nervous system is not happening, the reflex tachycardia, baroreceptor reflex is immature, so the reflex tachycardia doesn't happen. And the parasympathetic system in the neonate is fully developed. So this discrepancy in parasympathetic and sympathetic nervous system, so any increase in autonomic tone may cause bradycardia via the vagal stimulation. So the main causes of reflex bradycardia and hypotension in pediatric age group under anesthesia, it is usually the vagal stimulation by laryngoscopy, tracheal intubation, and tracheal suctioning. So we should take care about this.
So coming to the fourth question, in normal newborn, the functional closure of the foramen novel, which occurs at age of the life, answer the questions. Options are A, 1 hour of life. Option B is 1 day of life. Option C is 1 week of life. Option D is 1 month of life. Option E is 1 year of life. Which is the correct answer for this question? So most of them has given D and some for A. Let's go to the explanation. Actually, things that for closer functional closure uh, in intrauterine life, from left, the blood flows from right to left, because the right atria pressure is greater than the left atria. So when at birth, what happens? The main reason for the functional closure of the foramen novel is the increase of left atrium. Because of the increase of left atrium, the foramen novel closes. Then what is the causes for increase of left atrium? As our Dr. Animes has explained, because there is a decrease in PVR, that is pulmonary resistant, vascular resistant, and there is increase of SVR, that is systemic vascular resistant. Because of that, the left atrial pressure increases, which causes the closure of the functional closure of the your foramen novel. So it occurs usually the first hour of life. But for anatomical closure, it takes almost 3 months to 1 year. The answer is the first hour of life. Go on.
The next is the nervous system. Coming to the central nervous system, the babies have a relatively large brain per kg body weight. That's around 1/10 of the body weight in the newborns. And its weight of the brain, it doubles by 6 months of age, and it triples by 1 year of age. The cortex and the brainstem get developed by 1 year of age, but the myelinization, it continues till 3 years of age. The blood-brain barrier of the newborn is immature, therefore early CNS involvement is seen in case of jaundice, and there may be drug toxicity due to immature blood-brain barrier. The intracranial pressure, it is usually low in newborns, but any rise in the intracranial pressure, it can be compensated by expansion of the fontanelle and or separation of the sutures. Next, coming to the CSF volume, they have increased CSF volume per kg body weight. It's around 4 ml per kg in a newborn, 3 ml per kg in infants, and 2 ml per kg in children. Therefore, higher drug dose per kg of body weight is required during subarachnoid block. And the spinal cord, it ends at the level of L3 in neonates, L2 to L3 in 1 year of age. Therefore, a lower level of subarachnoid block should be given to reduce the risk of spinal cord injury in the neonates and the children. The neurons of the newborn and the infants, they are thin and unmyelinated. Therefore, they have faster onset of block during the subarachnoid block or any other blocks. The autonomic nervous system, they are relatively well developed at the birth. The parasympathetic component is fully functional at the birth, but the sympathetic component, they are not fully developed until 4 to 6 months of age. And coming to the thermoregulation, the babies are more prone to hypothermia because they have a large body surface area to weight ratio. And they have thin skin, and they have limited fat stores and inability to cope with the cold stress. The thermogenesis, in the thermogenesis, the shivering thermogenesis is not developed until 3 months of age. Therefore, the primary source of thermogenesis is the non-shivering thermogenesis, which is by the brown fat metabolism in children. The mechanism of heat loss, the heat loss occur in the babies mostly by the radiation and the radiation, convection, conduction, and evaporation. The highest, the more heat loss is lost through radiation, and followed by convection, and the conduction and evaporation, it's comparatively less loss. But when the baby in the OR room, when any compartment is open or exposed, in the body cavity is open, the heat loss may be high through evaporation. The low body temperature may cause increased oxygen consumption, respiratory depression, metabolic acidosis, decreased cardiac output, and increased risk of infection. Therefore, and we should always try to maintain the normothermia in neonates and babies. So for maintaining normothermia and prevention of hypothermia in the OT room, we need to have adequate ambient temperature by just like we can switch off the ACs, use heater, room warmer, air blower, and etc. And less exposure of the skin and tissue by wrapping them with blankets or plastic drapes so that the heat loss is less. And also we can use warm IV fluids to maintain the body temperature.
Sir.
Okay, so the next question for the audience. The following are controllable factors for the maintenance of normothermia in neonates, except, so the question is except, warm environment, warm IV fluids, metabolism of brown fat, airway humidification, and forced air warming.
Most of the people have answered option C, I think.
Yes, so Dr. Depo, which one is the answer? Okay, so
it is C, metabolism of brown fat.
yes, so why do you think that this is the answer? So the important part is the heat maintained in a neonate is not by shivering, because the amount of muscle tissue is less. The muscle tissue is immature, does not have much of a calcium. So all these are the things by which the muscle tissue cannot generate the great amount of heat needed because of the heat loss. And the major and the primary way that a neonate maintains the temperature is by metabolism of the brown fat for heat production, right? And there we have also seen that the surface area is much larger than the body weight. So the ratio of the surface area to the body weight is much, much higher than an adult. Therefore, the heat loss is also maximum. The second thing is there is immature sympathetic regulation. That means the sympathetic system is immature. Therefore, vasoconstriction does not happen to a desired or to a protective extent. Let's say it that way. So all these are basically why, especially a neonate, goes into an hypothermia even if you keep him in an ambient temperature, right? And therefore, you use all these measures to keep the temperature at the same level. Even the OT temperature should be brought up in a sense, right? So the important part here is what we miss out in most of the cases is whenever we are doing a neonate or an infant, we should be very careful at maintaining the temperature because in most of the cases, whether we realize or not, hypothermia is really a practical big issue. Thank you. Let us proceed.
Okay, thank you, sir. So next organ system, we'll go to the abdominal and GI systems. So first is the renal system. So renal function in general, it is immature and reaches to adult level by 2 years of age. So immature renal function essentially is due to first is the low renal perfusion. So in utero, the blood supply the kidney is getting is about 3% of the cardiac output, while which increases in adult gradually up to the level of 20 to 25% of the cardiac output. So the glomeruli functions are also immature and they have immature tubular functions. So glomerular filtration rate, it is around half the adult levels. It is around 65 ml per minute in newborn, while it is 120 ml per minute in adults. Due to these reasons, there is reduced excretion of free water, and there will be an increased half-life of drugs or increased duration of action of the drugs that are primarily excreting from the renal system or kidney. So the any drug would be having a high priming dose of the in neonates, while we have to lower the amount in the maintenance dose as the clearance is decreased. Next is the hepatic system. So in a hepatic system, the phase one reaction system.
Dr. Animesh, just a minute. If you come to the renal system, one thing also is very important. These neonates and infant also suffer from hyponatremia. This is also very important. And it is basically because of this immature glomerular and immature tubular function, they cannot absorb, and most of the sodium that comes into the ear gets filtered, and this immature tubular function cannot hold on or cannot take back the sodium from the tubules. So there is a good amount of sodium loss because of this immaturity. So this is also an important part that hyponatremia is quite common in the neonate and the infant. Please go on the next one.
Thank you, sir. So next is the hepatic system. So in the hepatic system, the phase one reaction system which involves cytochrome P450. It reaches up to the 50% of the adult levels at birth. So while the subcomponent of this cytochrome like CYP3A, it is fully developed and has got adult levels at birth also. So and next is the phase two reaction system which involve conjugation. They are quite immature in neonates, and since the bilirubin is the one thing that got excreted via conjugation or this type of reaction system, it leads to physical jaundice, especially in the premature babies. And the half-life of the drugs will be increased with the drugs, especially which are excreted through this phase two reaction or conjugation. As infant grows, ability of the metabolized drugs increases drastically or very rapidly due to the fact that the liver blood flow also increases, and the enzyme system, which even when if they are matured at birth, they are not induced by their substrates. So as the infant grows, the these enzyme systems get induced, and this ability to metabolization, it increases quite quite rapidly. So the neonatal liver, it is unable to handle a protein load. So if we are giving the neonate the significant protein diet, it would not lead to the significant weight gain. So and the total protein and albumin levels in the neonate or infants is also low. So the drug effects or the duration of action would be quite longer with the drugs which are highly protein bound or bound with the albumins. So examples are lidocaine, diazepam, and barbiturates. So, and there are few other drugs like caffeine and cefuroxime, which can displace bilirubin from the plasma protein. So this would lead to the free bilirubin increase, and it may cause kernicterus. Next is the glucose metabolism. So newborn has reduced glycogen stores and impaired gluconeogenesis. So it will lead to hypoglycemia, and so hypoglycemia is quite common in infants and neonates, and it may lead to neurological damage, especially in preterm neonates. We have to we should be take care of this, especially in preterms. So for this, we should be doing regular glucose monitoring, and and treat hypoglycemia with dextrose infusion. Hyperglycemia as such in neonates, it is usually iatrogenic. So coming to GIT, the gastric pH, it is alcoholic at birth, but it gets to normal physiological range on second day of life. And the ability to coordinate swallowing and respiration is mature only after 4 to 5 months of age. So preterm newborns, they have very high incidence of gastroesophageal reflux. Next is the hematology and fluid. So as far as blood is concerned, they have predominantly fetal hemoglobin at birth. Around 70 to 90% of the hemoglobin is of HbF type. This HbF or fetal hemoglobin has a higher affinity for oxygen, and so uh, there it has the left side shift in the oxygen dissociation curve. Hemoglobin levels at birth is quite high, 16 to 24 gram percent, and this hemoglobin F or HbF shifts to adult type HbA by around 3 to 4 months of age. So there is also increase in renal erythropoietin in utero. So it leads to increased RBC production. This erythropoietin level decreases gradually after birth, and in neonates there is low level of 2,3 DPG. So yeah, in fetal circulation in utero, it is relatively it is hypoxemic. So to counter that hypoxemia, there is more HbF and increase erythropoietin levels. Both of these values decreases gradually after birth, and especially in first 3 to 4 months of age. So it will lead to physiological anemia in first 3 to 4 months. Premature babies, it is more profound, as they are premature in erythropoietin levels are already low, and it even get decreases after birth. So it may even lead to the point that we have to transfuse blood in the preterm neonates. In coagulation system, vitamin K dependent clotting factors are reduced or deficient, and platelet functions are deficient or immature, while platelet numbers are quite good. So next is the estimated blood volume. So if we go for the per kg body weight, the blood volume is quite high in preterm neonates, and it term, or if as the age increases, it decreases gradually. So in preterm, we have to take around 90 to 100 ml of per kg body weight as estimated blood volume, while in term we can take around 80 to 90, and gradually we can decrease as per the age. Fluid distribution. Uh, so the same thing, that total body water in infants and neonates is around 50 to 80% of the body weight. So in preterm babies, it can go as high as 80 to 85% of the body weight, and in neonates it is around 75 to 80%, while as the infant grows up to 6 months or up to 1 year, it reaches up to the 60 to 65% gradually. Another important thing is the ECF and ICF ratio. So extracellular fluid is the component of extracellular fluid is quite high in neonates, and even higher in premature babies, and intracellular fluid component is lower. So if we see the ECF to ICF ratio is in premature babies and compared to adults, it gets reversed gradually. So the premature babies can have 50% of the body weight as extracellular fluid, and in during with intracellular fluid is as low as 30%. So as the infant grows, and via infants to adults, it gets reversed and go to the level 2040. So the blood loss, the fluid loss would be more in premature babies, as they have higher ECF volume. So the fluid requirement, in general, 100 ml of water is needed for each 100 kilocalorie of expenditure. So in first 3 postnatal days, when full-term neonates require only 40 to 60 ml per kg fluid per day. Uh, uh, but in OR, usually when we have to calculate the required volume we have to give, so we calculate it first. We give in three or 4 points. First is the maintenance fluid, which we calculate by Holiday Cigars formula, which is 4-to-1 rule. And the next is the estimated deficit. So we take the fluid deficit, which is present in the preoperative time period, and we whatever is the amount of whatever is the duration of the hours, we multiply it with the maintenance fluid, calculated by Holiday Cigars, and the deficit volume, we do not give the whole volume in one go. We divide it. We can give one, especially in children, we give 1/3 of that volume in first hour of the surgery, and divide the rest of the volume in the rest duration of the surgery. And with the severity of surgical and non-surgical trauma, we divide the surgery and take the factor that is that we can go with how much fluid loss is there, how severe is going to, so the surgery is going to be. And the and the ongoing blood losses or fluid losses, they need to be replaced with uh, appropriately with crystalloid, or in severe cases with blood also. So this is the 4-to-1 rule of fluid therapy. We can see here, this is why first 10 kg of weight will take 4 ml per kg, next 10 kg 2 ml per kg, and the rest with 10 ml kg. So
I think this will be the last question. A 1-year-old infant weighing 10 kg is scheduled to undergo elective herniatomy. How much is the estimated maintenance fluid requirement per hour? We are telling about maintenance. So what will be the answer? The options are A 100 ml, B 40 ml, C 10 ml, and D 80 ml.
Sir, I think everyone is going with B.
I think what is the answer, Animesh? It's a 40 ml. If you go by Holiday Cigar, it's a 4-to-1. So it's 10 kg. So first hour, so we will multiply 4 by 10, so 40 ml. So B is the right answer.
So these are our references for the presentation. Thank you very much.
Thank you. I think there are two questions in the chat box. First has already been answered. Why does pediatric age group have reduced serum creatinine level? So Sering ma'am has already answered that question because of reduced muscle mass in the pediatric patients. And one more question is there. What is and regarding NPO status in pediatric patients? Is it taken from the last food or liquid or since morning?
If you go by new guidelines, actually it's a new guideline to pediatric patient, we can put into NPO for clear fluid for 1 hour, because one thing is very clear that pediatric patient can go for dehydration. So it's they can go for dehydration. So according to new guidelines, they have put 1 hour NPO for clear fluid for pediatrics.
Okay, thank you, sir. Any more questions? Okay. I think there is no question regarding today's session anymore. Over to you, Madhuri ma'am.
Yeah. I think sir is here. Bajwa sir is here. But thank you for an excellent presentation on the differences between the child and the adult. So there are so many differences. And one question which is very often asked in the PG exams, especially during Viva, is what is the difference between a baby, a child, and an adult? So whatever case, you one pediatric case, you always get in the exams, right? Appu and Animesh?
Yes, ma'am.
Always get a pediatric. Most of the students will get one pediatric case for case discussion, whether it's DNB or whether it is MD. So this question is a very favorite question of examiners. Tell the differences between the adult and the child, or difference between pediatric and adult airway. So you have given an excellent presentation and covered almost all the points. And I think your main reference was Smith's, right? Smith.
Yes, Smith and Miller. Yes, ma'am.
Smith and Miller. So very well done.
Thank you.
And
you.
I have a question to you.
Oh.
Can you elaborate something on the surfactant? You know, surfactant will be present na, in the
Yes, ma'am.
neonate. So can you tell us something about it? Like when is it produced? And what is its function? And where is it is produced by what? Can you tell?
Then surfactants, they are produced by type 2 pneumocytes.
This is a bouncer question for you. I'm sure you have not prepared. So whatever you know, you please tell. Don't worry. Yeah.
And they are produced by type 2 pneumocytes in the alveoli.
Excellent. Yeah.
They usually the surfactant production starts by 16th week of age.
Yeah.
But
Around 22 weeks. Yeah. And it peaks at 36 weeks. Okay. Then
the surfactants, they are like
what is the function?
They
It decreases the surface tension
Yes,
inside
they
the.
stabilize the alveoli.
Yes,
to
So
prevent them from collapsing.
collapsing.
And they, because of that, the inspiratory force which is required to expand the lungs decreases because of that. So what happens at birth? What happens to the surfactant production at birth? So this production can be hampered at birth, especially because of hypoxia, hyperoxia, acidosis, and hypothermia, which are very common at birth. Okay,
Yes.
and so that is
Yes,
why
ma'am.
these have to be corrected. And if there is a lack of surfactant, you know very well,
It
the
is go
alveoli
to
are going to
respiratory
collapse.
distress.
And there is a risk of what else? The ventilation is going to get mal-distributed, and there will be impairment of the ventilation.
Patient perfusion.
Yeah, there'll be impaired gas exchange, and there'll be decreased compliance of the lungs. Okay. And can you give surfactant to the baby then? You
Yes,
can.
ma'am. Yes, ma'am. We can.
Through an endotracheal tube, you can deliver it. Okay, with the help of positive pressure ventilation. Okay. Is there any way to, this question is also for Repo and Animesh.
Yes,
Is
ma'am.
there, what are the various methods to estimate the size of the endotracheal tube in children? Like now, you have described the entire airway anatomy, which is the narrowest portion of the airway. Everything you discussed in depth. Very beautifully you have explained. So now just a clinical application of it.
Ma'am,
Tell the age-old methods and the modern methods.
So, madam, we can use the formula as
Yes.
calculation by
Yes.
h divided by 4 plus 4. So
Huh?
for this is for the cuffed tube, sorry,
Huh?
uncuffed tube, and for
Huh?
cuffed tube we decrease it by 0.5 mm. For
Okay.
so
Any other method?
we can use the little finger of the baby,
diameter.
so
Wonderful.
and take
Yes.
it as an internal diameter.
Yes. Any other
Uh,
method?
Otherwise, we can use this ultrasound or
Yes,
newer.
that's what I wanted you to tell me. So what is that by ultrasound? There are people are trying to measure with the help of ultrasound, right?
Yes, ma'am.
So what is the application of ultrasound in the neonatal airway or in the child's airway?
So we can see the trachea,
Cricoid cartilage.
Okay.
especially cricoid cartilage, when we can measure the diameter
Yes.
using that probe,
Mm-hmm.
and we can see that usually what happens is that if we even if we take the correct size tube, then since the narrower portion is a subglottic region of cricoid cartilage, it passes through the vocal cord, but it get in the
Yes.
pass through the
Yes.
subglottic
So you
region,
can find out which is the narrowest part.
narrowest part. So
Okay.
ultrasound
Then
we can see it
you
clearly.
can look for subglottic stenosis.
Yes, ma'am.
You can look for various tumors or, whatever, vocal
Yeah.
cord papillomas,
Any
all those
congenital deformity
pharyngeal
also.
webs, all those you can see. Yeah. I think Bajwa sir is here. Sir wants to ask something.
नहीं मैं थका हूँ everything over.
No, discussion is going on.
Okay.
Estimation of tube size is going on.
Regarding this ultrasound for the airway, is it a complete assessment tool for the airway in pediatrics? It's a high-end question for the PGs. But the thing is that in the ultrasound, when you are using it for the airway, the pediatric airway is a very dynamic airway. It's a very dynamic, small. The correct assessment from the anterior posterior to lateral part is a very difficult because you require a three-dimensional USG for that. It's basically all the airway ultrasound that we are doing are the two dimensionals. You may see the one plane, you will see that this is a narrow part, but overall the assessment of pediatric airway, you can say it's a bit tricky with a USG. Adult maybe still you may be able to do, but in the pediatrics, because dynamism so much, the collapsing nature of the airway is so much there because even the cardiac rings are not, they're very soft. So the dynamicity part is a very, very limiting factor for a correct assessment of the exact airway. Yeah, still then you will be able to know the little narrow part about that. Regarding this anatomical and physiological differences between the pediatric patients, my question to you is, you both are third year now. I've given you one specific kid in the night emergency duty. It's coming to you with something, some emergency from the, maybe laparotomy may be required. So how are you going to secure a line in a chubby baby in the night where the no veins are visible? That is the most important question for me. If you can secure a line, anesthesia is not a difficult part in that part. How you will proceed with that? If you can answer that, you will pass your examination. Your third year, emergency duty at around 12 o'clock in the night. Dr. Nami is not picking up the phone. She is not going to come to help you out. Dr. Sanyal sir is also not there. He's out of station. So you have to do it. No consultant is picking up the phone, but the child is having a life-threatening emergency laparotomy.
So
So what
first
I
we
can
will
suggest you?
go. We'll go for the peripheral lines.
How
If we
will you
can
go?
see
Chubby,
anyone.
chubby. It's a chubby. That's why chubby patient.
Yeah, can you? So we can go for the central venous
Straight away.
catheterization.
Are you good enough to take the central venous line yourself?
So even in the peripheral line, we can use the ultrasound.
See, the more important is in the chubby patients, there are two small arms. One or two attempts, it's gone. Somebody is writing the USG guided. US is not available in many institutes. At night also, how can you use the USG also? One thing, if it happens to me, first thing I will call whom? I will call a pediatrician first. Because they have got that infrared technology with them, the vein finders, which is not, even if you have got anesthesiologist has got with them, they may not be knowing at what plane rightly to insert into that. Because the vessels which appear in that vein finders, you are not good enough to, you can pierce the vein there only. It's a countering. So I will always like to find out a pediatrician because these are the methods which requires a good training to secure a line there. It's a project, it's a big project in any chubby child or any obese child to find a line. So if you think you have a pediatric resident, third year resident on duty, you call him. That's the first helpline for you to secure a line. Because by the end of third year, you are very well versed with the anesthesia techniques, how to go with the pediatric patients. But the peripheral line sometimes become a project. You can't spend 1 hour on securing a line when life-threatening emergency is there. If you say intraosseous, you have to maintain because intraosseous is always for the emergency resuscitation. Now you are doing for not just resuscitation, you are going for even the, what you call, proper balance. You have to see the input and output. Everything has to be seen. So these are the things. So this securing line is very important. But in trauma, you can go for the intraosseous. You know the site of intraosseous?
So the tibia.
Which part of tibia?
Shaft.
Not shaft. Not
Shin of
shaft. Where you really secure. You should be knowing the mechanism of also circulation. If you are putting it intraosseous, it's always know the mechanism of circulation from that particular part. How much fluid you can give in this one, intraosseous side. That is also very important. You know the tibial tuberosity, you can just, below the tibial tuberosity, there is a way you can take it as a guidance to insert the intraosseous. You have to take a very hard needle for that, for intraosseous. But if you have got a pediatrician with you, you may have to secure 2 lines. You may have to secure 2 lines also. Central venous sometimes is not accessible in these cases. That's the most difficult part in a pediatric patient, which I think over the last 26 years, which I've encountered. Securing a pediatric line, IV line in a patient for emergency surgery with the obesity and that thing. Rest, all emergencies are there, which we read about, which we consult our seniors and we can do. But it's a very practical part. I think even the practitioner faces the same situation, or the professor in head faces the same situation. I think Dr. Naimi and Dr. Sanyal sir will be able to dwell upon it more importantly. Sanyal sir.
Good evening, Professor.
Good evening, sir.
Yeah, and that was a very good question. This is actually comes in, but the pediatrics here, we have a pediatric department and they have postgraduate students. We don't have an infrared, as far as I know out there, but they are good in securing the IV channels as such. So we, most of the time we need not bother, but in sometimes it definitely is a problem. It's a very common problem. And you get frustrated over it. That is sure. Once it doesn't go the next time, doesn't go the next time, change hand, it doesn't go, change the parts from upper extremity to lower extremity, it doesn't go. So this is a very good question as such. And from our part, basically we try to tell them that you also secure EA. They are good at securing IV lines somewhat, but our pediatricians are quite good here in securing the lines. So.
Yeah, that's actually a reason, sir, because the pediatricians are the helping hands to these type of cases. So sometimes the management of these cases become a little polydisciplinary. You involving the pediatrician, you may be involving some surgical or other ENT person involving with you. Life become easier because you have to give anesthesia also. We don't have to, can't forget that. After securing line, the anesthesia part is also very much turbulent. So I think rather than spending our entire energy and getting exhausted in anesthetic this patient, this is a common thing we face in our postgraduate days in the third year, especially, or when you become a new senior resident, when everything is dependent upon you for the emergency. Rest all the airway things you all be must have studied too much. Those things, how to manage with the supraglottic devices, LMA, cup tube, one cup tube, those things keep on coming. Then coming with emergency like gastroschisis, diaphragmatic hernia, and all those tracheal fistula. Those we always keep on studying so hard that we forget the sometimes basic things. It's the basics. That's why this class is meant for that only, the basics of anatomy and physiology. This is very, very important
And
because
what
one
is
year.
more important, sir, what you have discussed with the IV line, it is more frustrating. Even if you are very experienced, if you are not doing it regularly, even you think it to be experienced, even if you are experienced, at times it becomes a really frustrating thing to happen to you. And you are you are at your wit's end what to do now.
And we have to sacrifice our, egos here, glory. We are not working for a glory. The pediatric patient's life is at stake. So if we have got a help, sometimes mental block is there, the clinical block is there, your fingers are at a block. You cannot ensure the smoothness of line. Center line is okay, but again, the center line has got, sometime in a pediatric patient, it's a very traumatic. Every structure is so close by. So even if you are not well versed with ultrasound guided central line blockade, provided first you have ultrasound with you. The next part is how much learning you have with ultrasound. Because even with ultrasound, I've seen people almost puncturing aortas with ultrasound also. So that is another part. So securing central line is a good enough for these surgeries, but that is a thing last resort. Blind central line in the pediatric patient is not advocated as such, but always done when it's a life-threatening thing, when you can't secure anywhere else.
And as it is a life-threatening thing, central line becomes much more difficult because of the retraction and then the collapse and everything. The second thing, sir, as you said, that you cannot very well distinguish even in a very, very, very highly high frequency probe. And third, the neck and everything, the anatomical differences and everything make it very difficult for pediatric. Neonate and you leave it. Even pediatric, they become very difficult. The space that you need to manipulate is much, much more in adult. So as you do it in adult, we see it very clearly and we do it. We think we can do it in a pediatric, but it's a different story altogether.
And any bleeding complications you cause, that is going to be catastrophic because pediatric patients cannot lose more blood. You puncture an artery, and it's very difficult to, although you may be able to press certain tissues to stop the bleeding, but even a small amount of blood, even a 10 to 15% of the volume, if goes out of the artery, you will be landing in a shock like state immediately. They don't have that compensatory mechanisms for this type of shocks. Pediatric patients have a less blood volume. So 10% to 15% is very vital for them, even that. You can't wait for 30% loss to be declaring it an emergency. 10% is good enough to cause an emergency. So these are the small things from my side because pediatrics are the most important. Differences between adult and pediatrics, because we always treat them, that one common idiom coming from a long time, that don't consider pediatric patient as young adults. That is always a gold line. Whenever you say to the examiner, say like that. The pediatrics are not the young adults, or the adults are not grown up pediatrics. On the other way side, if you go like that. So this is the only difference. The rest of the things are fine. You can go ahead with that. Anybody's the screen coordinators, Nisha and Arunima, you can invite the questions from others.
Yes, sir. Thank you, sir. Uh, any others having question? There were few questions, but I think those have already been assessed. Most of the people wanted to discuss regarding post-op fluid management in pediatric patient and ideal fluid in pediatric cases. So, sir has already discussed regarding uh, hypoglycemia and use of normal saline with dextrose. Any other queries?
Or you can ask for suggestions also. If
Sir,
not, then
I
I
think,
think
yes, sir, all the queries I think which have been asked in the chat box have been already addressed. Uh, any suggestions to all the viewers? So someone has asked regarding the, I think they are asking for the
we will answer that.
inhalational agent.
Nisha, we will answer that after this. Let us felicitate first
Okay, sir.
to Sanyal sir, Ramapati Sanyal sir. So, sir, because of your team, your institution is doing a very good job. And anesthesia at remote locations, the northeast part is such far away from the central stream that you may getting resources at your end, but the connection is with not with the because I've been into northeast lived there for almost 5.5 years. I know what difficulties we really face when it comes to the specialty things also there. You are doing a very good job there at Naharulgunj, sir. It's a wonderful display of the anesthesia skills. And Dr. Naomi, she was so exuberant and at that time enthusiastic also to conduct this class. And I think credit should go to you and Dr. Naomi for being the leaders for these classes. You have taken initiative, and thank you, sir, for being the leader of this class and the captain of the ship.
Thank you, sir. Thank you, and thank you for the appreciation. I do owe my all my credit not to me but to my whole department, including Naomi, Dr. Naomi, Dr. Lucy here, and the others in the department. They also put in a great effort to make this whatever you have seen today. We have seen today. It was difficult for us because the internet connection and all those things are very difficult out here. As you know, you have been in Assam, you have seen those days. So it has improved much a lot, but they made a extremely good effort, my department, to put this together. Thank you.
Yeah, and definitely, sir, Dr. Naomi also, because these classes now this class will be available on YouTube. So everybody can go through the physiology and anatomical difference between adults and the pediatrics, and that's a way to remember the things. Sometimes you keep on reading the physiology and anatomy of the pediatric patients, you may not be able to remember, but when it become a comparative valuation, become easy to remember also everything. Thank you, Dr. Naomi, for taking
Sir,
all
we
the pain.
are very much indebted to you for giving us this class.
No, it's
Actually, we want to thank you.
your hard work. Then Dr. Tajil Lucy, she was also there, and he was, I think he does more of the efforts in closer to the PG students than Dr. Sanyal or Dr. Naomi. He's more close to them. So thank you, Dr. Tajil,
Thank you, sir.
for being with us today.
Thank you, sir.
And Milo Apo and Animesh. You were good, confident, and good thing. And I did not interact with you much, but still did not make a blunder. That's the best part. So I know in Northeast, when we answer even the Viva, we don't make many blunders there. I know that. This is a common thing going there. We stick to the basics. Thank you, both of you.
Thank you very much, sir.
And Nisha as well as Arunima. So Nisha, she is there with even with the small child, giving all the care of family, and Arunima also with all responsibilities. Both of them, thank you very much for this class.
Thank you so much.
Thank you so much, sir.
And I think you keep on rising with this type of, it will give confidence to you also for the future. And Dr. Madhuri, Dr. Ridhima, Dr. Nishan, they are always there to help for these classes. So I'm very much blessed to have all these people with me to continue in this class. Nisha, there was some question you were asking at that time.
Yes, sir. There are a few questions. One is regarding the ideal inhalational agent to be used for pediatric cases. I request our esteemed faculties to address this question.
So I think
I
it's a
think
very
the
simple,
answer has already
very simple
answered
question,
regarding, yeah.
very simple answer also.
Despite of this, if anyone is having another query, they can ask. And another question is regarding our sessions. Dr. AG has asked if these sessions are happening more and more. Yes, these sessions are already happening and we have recorded videos on YouTube ISA National Online PG Class channel. You can access them at any point of time.
Anytime, whenever you're having lunch or dinner, you can see them that time also. They can save your time. You can watch them anytime when you're relaxed. When you're not under pressure, you see them at that time. You will come to know all the questions being asked. And one of the person, I met in this one, Jhansi or somewhere else. Yeah, and the person told me, yeah, they told me that I used to watch these classes, and the next day when I go to the class, I ask all those questions which I asked in the class to the my PG student. They are always, get impressed, sir. How much, sir, do you know about these things? Then he told them last Monday that I told them these I always am buy from the classes. So that is one of the professor who told me this thing. So I was a little bit more surprised and shocked at the same time that after listening to these questions, he goes and asks the question to the PG students. So this is the thing. Any other question there?
No, sir, I think we
No more
have.
questions, sir.
So I think it's a very basic class, good for everyone to understand these things.
Just sir, one thing to add about sevoflurane, definitely a less intense choice, but another thing is interesting about sevoflurane. The MAC of sevoflurane, usually what happens, the MAC during the infant and the adult goes down. It's more in the middle pediatric group, the toddler group. The MAC is more than, less than in the year. But what happens with the sevoflurane, the MAC remains throughout the same. The MAC doesn't change with the age. So that is another important part why sevoflurane can be a choice for the pediatric patient. The MAC does not change with the age. For other inhalation anesthetics, they can change with the age. But this is again one of the important, one of the points that can happen. But the major point is definitely non-irritant.
Yeah. And more importantly, I think over the years, if you ask when we started using the sevoflurane first, it has made such a good psychological impact on our minds. Whenever the SIVO, this one, we are using SIVO as compared to the even used to using the halothane and then isoflurane, it becomes so secure to use. No? Sometimes it so becomes secure. You just put it of 5. You go to the 5 concentration of 5 and the marking of 5. You don't feel any, something panicky. It doesn't matter if it's 5 and another 4 or 5 breaths the child is under, and you can always decrease it. So safe to use in any concentration at the beginning, although they are not recommended. But it has given us a very psychological cushion over the years, the sevoflurane, because all the properties associated with it is all the pediatric friendly properties. It has made us, so much free to use it any place, even if it is used in a periphery. We are always say that even if TIVA is not available, so SIVO can always be the best friend to us. And we can always titrate it, as sir you said about the blood partition coefficient also. It's very easy to titrate these SIVO.
Thank you, sir.
So
And I really want to thank you, sir, for giving us this national podium and enhancing our confidence. And we have some positive inputs also in the chat books regarding great presentation. So
these always come, and there are
congratulate
few
to all
very
the
good
team
friends.
of.
Very good friend, Dr. Mohan Pathak sir is there is a very good friend of ours. He's always give us, he always gives a good presentation because these are very hard work. Because the PGs are doing hard work, the teachers are doing hard work, and it is present in a beautiful manner, and it become very concise and comprehensive when they present. Now he will say something. I wanted to hear from him. That's why I took his name. Unmute, sir. Unmute yourself. Pathak, sir. Sir, you are muted.
Unmute.
Yeah. Now
Hello.
fine.
For MRI anesthesia in the MRI room, we used to give ketamine in pediatric, but you cannot use in the epilepsy patient or below the age of 2 years. So other option is to intubate and ventilate, I think. No, for MRI anesthesia,
Sir,
MRI
for
brain.
intubation and ventilation, you again require oxygen cylinder actually. You require, or you have to use.
You need anesthesia machine, which is very rarely it is
Sir, actually, it's
available.
not available everywhere, but definitely
Not
where
available.
MRI centers are there, they will definitely have MRI compatible anesthesia machines also. But sir,
Yeah,
ketamine,
and they
regarding
were,
ketamine things have
uh,
changed over the time. It's the drug invention, reinvention of the properties of ketamine. You can still use it, but only provided that the ICP doesn't increase that much, which is written in the books. If you go by it, one dose is not going to cause a catastrophic rise of ICP. Even with epilepsy, also, sir, it's not that a drug will cause epilepsy immediately. The more
they
important
want to
is
invest. MRI patient comes for epilepsy only. For
Hmm.
epilepsy only they come for, and ketamine we have restriction to use.
Yes, sir. Sorry,
Usually they come, yeah. Usually they come for the investigation for epilepsy patient, no?
Mhm.
And there only we cannot use ketamine, but sometimes we use because the otherwise it is difficult to give total GA with intubation and all. You keep them over because there you need absolutely immobile patient for MRI anesthesia.
Sir,
Absolutely immobile. Even little movement also doesn't
sir, the advance
allow.
of the NORA, things have changed a lot. There are so many recommendations of NORA. You are getting the supraglottic airway devices. You are using the sedation or the conscious sedation as the term, which has already been obsolete now. But sedative properties of the few drugs are very important, depending on the age of the pediatric patient, the cooperation of the pediatric patient, the restlessness. So many factors to consider. Then rather than just going intubating and then giving anesthesia, that is the last resort, sir. I think we should keep it for when all the
Last
drugs.
resort. Last resort.
Yeah.
Yeah.
Rather
It
than
should be safe also because it is a anesthesia in the remote place where
yeah, NORA, sir, is a
not much of a
non-operating room
facility and
anesthesia is
health.
always difficult, sir. And especially we should be knowing the limitation of our resources, our manpower, our setup. That knowledge about that setup is very, very important before proceeding forward. Because those are the important part. We should not land up for doing anything, any adventurous thing, just for the sake that we can do these things. We have to ensure the safety of the patient first before we move further to give any type of administering any type of anesthesia.
Yes, sir. You
Yes.
said a very good
Really
thing.
nice.
This outpatient patient, as Dr. Pathak was saying, giving anesthesia in an MRI or a CT outside the OT, you should know your manpower and the limitations. That's very important, especially in very periphery, in remote places and in our institute like that, because that is a very important thing. Because the manpower is always not there. You are not associated with the environment. You go very rarely or once or twice, and then you are trying to give an anesthesia, and that can be very catastrophic. And it has happened. You are very right, sir, in that.
Dr. Madhuri wants to add.
Yeah, I just wanted to add to that question by Dr. Mohan Pathak. Sorry, instead of ketamine, of course, we can use little higher doses of midazolam. We can use propofol. We can use dexmedetomidine also. And of course, we prefer to, if you're giving deep sedation, and we can even use sevoflurane if you're keeping on spontaneous ventilation.
No, but I think when
So
we are
we can
giving
use
this,
all these agents, not just
Madhuri,
ketamine alone.
I told that
Ketofol.
depends upon the age of the pediatric patient
That's
also.
what, depending upon the age.
And
All
also,
these.
moreover, when you are giving the deep sedation, deeper plane of sedation, I think the airway patency you see yourself.
Yes, of
Because the
course.
monitoring of the airway patency is you may see the monitor, but the monitor will be telling you something after 3 to 4 minutes. Those 3 to 4 minutes of hypoxia, because patient's saturation will not fall down if you are seeing just the breathing pattern also. So you have to keep a very close vigil when we are going for those deeper sedation or the anesthetic doses of
Yes.
the drugs, whether propofol or
Yes,
anything.
yes. Yes, yes.
Even the fentanyl also you are going to use.
Yes, yes.
So it's become more challenging, but I will, in my experience, if you ask me how to give anesthesia, I will just like to go with the technique which is most learned by me over the years, which I'm most comfortable with, where I can ensure the safety of the patient. Even Dr. Pathak said, if I'm more comfortable with the intubation and ventilation, I will definitely go with that. We should be that what I said, na, manpower, the resources, and help in case any emergency arises, how to deal with that particular scenario. That has to be seen in that situation. When
That's
we are
what we can use combination of ketamine and propofol, ketamine and dexmedetomidine, like
any
that.
drug,
Down the dose of
any drug
ketamine.
you are comfortable with, any drug you are comfortable with, but the patient safety is the priority in using any drug or technique over these patients.
That place is remote place, so you cannot take action immediately if airway problem comes.
That's what I'm saying, sir.
Yeah.
It's a individually, it's a customized thing we have to do for such patients.
Yeah.
I think it's
Thank you,
8:20,
sir. Thank you.
and from national headquarters, wishing happy Diwali to everyone, and especially to the team of Arunachal Pradesh who have presented a beautiful class today. It will become a permanent class on the YouTube, so you will be captured, and even our screen coordinators, Nisha and Arunima, will also be captured forever on those classes. As well, Dr. Madhuri and Dr. Ridhima are always there in all the classes. So it will be good for you can show the classes to anybody that these were the classes we anchored. And the students will be very happy. They have already cleared the pre-final today. So I hope Dr. Sanyal sir and Dr. Naomi will be keeping this much in consideration before giving them marks in the final examination. So it's a good one. I missed the first part because I was traveling at that time, but the later part I heard almost everything. So shall we say good night, sir?
Happy Diwali from our side.
Yeah, good night and happy Diwali and long live ISA.
Long
Long
live.
live.
Long live ISA. Thank you so much, sir.
Long
Happy
live ISA.
Diwali
Good
to
night, sir.
everyone.
Yeah. Now end by saying